Good afternoon. I am the Chief Medical Officer at Cecilia Health and would like to thank you all for joining our webinar today. I am an internist and an endocrinologist by training, and I have spent most of my career on the health plan side, serving as Chief Medical Officer of a number of health plans, and most recently 14 years as President and CEO of Metro Plus Health Plan in New York City. I joined Cecilia Health 2 years ago, and I am very excited to be discussing this very important and timely topic today. The swift adoption and uptake of telehealth services during the pandemic has been encouraging, given that we've long understood the potential for telehealth to improve access and patient outcomes. We were fortunate to play a large role in this shift to virtual care, as Cecilia Health worked with health systems and diabetes specialty clinics during the pandemic to provide clinical disease state knowledge, device support, and telehealth visit preparation. These clinics reported that at various points over the past 18 months, telehealth visits accounted for over 90% of their patient interactions. Our partnerships provided essential, non-emergency services to people living with chronic conditions, resulting in a positive impact on their ability to manage their disease and improve our partners' clinical operations. Some argue that the rise of digital health has helped create a more level playing field when it comes to access to healthcare. Others raised that this creates a potential digital divide based on socioeconomic status, thus adding another barrier to those who already struggle with access to care. We will look to discuss this point in more detail with our panelists. What is indisputable is that telehealth can live up to its promise when the playing field is equal and everyone has access to a reliable internet connection and a smartphone to take advantage of a virtual approach. At Cecilia Health, we take pride in our flexibility to use the right technology that best suits the needs of our patients in order to provide care and chronic condition education remotely. Through Cecilia Health's extensive experience working with people living with chronic conditions, we understand the value of taking a whole person care approach, addressing both the condition itself and other factors influencing outcomes. Research suggests that clinical care is estimated to account for less than 20% of what truly affects a person's overall health outcome, and the majority of factors that materially impact the person's health occur outside of the doctor's office. Social determinants of health play a key role in determining health outcomes, and it is critical that both digital and in-person care modalities seek to address them. Cecilia Health's expert clinicians can identify these SDOH barriers through conversations with our program participants and are able to help address them through a combination of referrals and chronic condition education. We also know that social determinants of health are one of the main driving contributors of health disparities. Our clinical team has come across countless examples of this through work with large populations of people living with chronic conditions. For example, people who don't have access to grocery stores with healthy foods, or don't know what ingredients and food types constitute a healthy diet, are less likely to have good nutrition. That raises their risk of health conditions like heart disease, diabetes, and obesity, and lowers life expectancy relative to people who do have access to healthy foods. Similarly, if people don't have access to resources to learn more about their chronic conditions and how to make lifestyle changes to follow their care management plan, either because of lack of digital literacy, such as the use of devices like CGMs, or availability of resources in their preferred language, that can lead to further negative impact on health outcomes. Our work with a large patient population confirms that the prevalence of diabetes and heart disease are higher among Black and Hispanic Americans. At Cecilia Health, we have built culturally adaptive programs to ensure that we are providing care that is tailored specifically to the populations that we're engaging with. As part of today's discussion, our panelists will share their strategies and opinions on how healthcare organizations can help to close these gaps and ensure better outcomes for these at-risk populations. When we talk about racial and ethnic disparities in healthcare, it is often hard not to view this through the lens of socioeconomic factors as well. We will look to explore these disparities further as part of today's discussion, as this is a key component to building a healthcare ecosystem that is better equipped to help as many people as possible. We have an exciting group of 4 panelists. I'm going to ask each of the panelists to do a brief introduction for themselves, and then we'll jump right into our discussion. Abdu?
Thank you, and super excited to be part of this conversation. It is obviously a critical time in healthcare, and it is a much needed conversation as we think about barrier and access to care for better health outcomes. My name is Abdu Ba. I represent Emblem Health. I'm the Vice President of our Quality and STARS department, and our organization is responsible to take care of our New Yorkers. So I am, again, super excited to be part of this conversation and provide some insight from the health plan standpoint.
And Amy?
Thank you, Dr. Saperstein. I'm very excited to be here today as well. Amy Kendall, Vice President, Complex Health Solutions at CareSource. For those of you who don't know CareSource, we're a regional health plan specializing in government programs, Medicaid, Marketplace, and Medicare Advantage and D-SNP plans in 5 markets in the Midwest today.
Thank you. Sabrina?
Hi, good afternoon, everyone. Excited to be here. As everyone else has said, I'm Dr. Sabrina Khan. I'm a seasoned healthcare executive. At present, I am consulting, but I am a psychologist by training. For the last 15 years, I've really spent in Medicaid and Medicare managed care programming at health plans. My most recent position was with the Parkland Community Health Plan, located in North Texas, right in the Dallas-Fort Worth area community, and I'm excited to be here.
Thank you, Sabrina. And Amanda?
Hi, good afternoon, everyone. I'm Amanda Parsons. I'm the Deputy Chief Medical Officer at Metro Plus, which, as you've heard from Dr. Saperstein, is the payer that he previously spearheaded. Our plan serves over 600,000 vulnerable New Yorkers. We're north of 70% Medicaid, have a real interest in making sure that every New Yorker has access to high quality, affordable care. My background is in internal medicine. Prior to this role, I'm fairly new to the insurance industry. Spent most of my time either on the payer side. I was at Montefiore Health System, large provider in the Bronx. And prior to that, I was at the New York City Department of Health under the Bloomberg administration, and really delighted to be here with you today.
Thank you so much. So we have our exciting group of panelists, and we're going to jump right into the first question. So the way I'm going to do this is I'm going to introduce the question to one person and ask all of our panelists to please add to our initial response that we get for each question. So for Abdu first, the shift to virtual care and telehealth has been dramatic during the pandemic, but it also highlighted the need for access to digital services and a stable internet connection. The question is there a digital divide given the broad prevalence of smartphones? Or is it the case that some digital health solutions are just not tailored to provide optimal care to certain subsets of the population?
Yeah, I think that's a very interesting question and topic, right? Because I think with COVID, one of the things that has been interesting is it did accelerate kind of the use of telehealth and virtual care. I think the one point that we do need to start with is access to digital broadband and internet connection has been essentially verified as something that, you know, about 80% of the population does have access to a digital device. I think where we need to think about the use of telehealth is a couple of layers. Number one, is it the right setting, and when is it the right setting to use telehealth versus in office, right? And then the second piece is having access to it does not mean that every member knows how to use it, right? So we hear from our physicians, we hear from our members that oftentimes, although they had a telehealth visit, they still want somebody to touch them. They still want to talk to the provider. And again, as we connect to the social determinant of health, some of those conversations are easier to have via face-to-face encounter, right? But with that said, we think about the positive from the use of telehealth and how the no-show rate significantly dropped for a lot of physician offices, where now members were actually being seen by their physician, where because of things such as transportation or things such as childcare prevented the member from being seen by their physician. So I think overall the impact is positive. I think we still have a lot of work to do to make sure that there's some conversation, number one, around the reimbursement rate for providers. What does this look like beyond and after COVID? And also, how do we make sure that it's used properly, right? Some of the health systems do a really good job of outreaching to members, making sure that the connection is working, making sure that they have all of the tools that they need before the appointment. And in some instances, a lot of members don't feel comfortable just yet using the technology and the science behind the telehealth platform. So I think having better platform and having the ecosystem, both from the health plan and also from providers, and locking our hands together to really support the member can be beneficial. So I'll turn it over and open it up to the group to provide some additional feedback.
Thank you.
I'll go ahead and jump in if it's okay. I think also something that has to be considered as well is location. Obviously, where is your membership? Are they in a more urban-based setting, or are they in rural areas? I know for us, where I recently came from, we had a lot of members in rural areas where the broadband capabilities weren't as rich or dynamic. I think we also have to think about, typically on telehealth platforms, there's a video component. Like today, it sometimes slows down the bandwidth. During the time of the pandemic, you also had people with children at home, so the pull was greater on bandwidth. So there were some issues there. Obviously, the education of how to use the platforms. Every physician office may not necessarily be using the same one, so learning which one. But I'll tell you specifically for us, what we saw was that it was condition based as well. If you had a specific condition, we treated a lot of pregnant moms, where I just came from. And with that, people have to be touched and felt typically during an exam. So doing that by telehealth is impossible. So as a result, what we found that it was a little decline with that population. But for some of our children's visits, obviously, we were able to get many of our members seen that wouldn't typically be seen. We had members with multiple children. So this really, I think, served as a viable option around scheduling for a lot of our families. So I think it was a good use of time there as well. But then also, too, I think overall education of the public. This is the first time in a long time, I think, that people had this as an option that they could choose. Before, it was smaller amounts that had access to this platform. So I think opening it up and relaxing some of the guidelines has helped as well.
Dr. Keene, I think that's a great point, the rural versus urban divide. And I think it's very easy to acknowledge and recognize that in rural areas, the digital divide is still a problem. There isn't always a good infrastructure for broadband. I think what we've seen at CareSource is that the same can also be said in some of our urban settings, where you tend to assume, I think, that the broadband infrastructure is really well built. And what we've seen is, yes, that's the case, but in some of your lower income areas, their landlords may not have invested in really the infrastructure to make sure that their tenants can access broadband. And so we've made some intentional investments working with community partners to make sure that we're also addressing digital divide and access issues in urban areas as well, especially in light of COVID.
Amanda?
I would say that when it comes to the digital divide, there are a couple different issues, and speaking from familiarity with the urban setting. So, New York City, as a result of the COVID pandemic, came to really, understand and attempt to tackle the digital divide, with close to 20% of the households not having good internet or mobile access. But I think that there are other issues when we talk about the digital divide. I think that there's a number of different issues in there. First is just can you jump on the web? But then secondly, what's your experience when you jump on the web? Is it that you have to share the one laptop between 5 people in your household, in which case someone's got access, but it's not you, right? Or it's you for some period of time before somebody else has to take the connected device. So does every individual in the household have access to the internet when he or she needs it? The other is, I think, many solutions that are available only in certain languages. Like I look at the utilization at our organization of our own telehealth solution that we put forth right during the pandemic. And I was delighted to see in our race and ethnicity data that there was sort of great uptake among African Americans, more so than in our white population or Asian population. But then when you look at the language, more than 95% of the language in which the business was conducted was English. And so right off the bat, from working in New York City that means that we're leaving some people behind. And it's not so much of a digital divide as it is like the language plus digital divide, right? That some of these, the websites or the applications are predominantly available either in English only, or in some cases like English and Spanish, but that still leaves a great many languages behind in a place that's so multicultural and so diverse like New York City. So I think for me, like when I think about the digital divide, it really is, a very complicated topic. And the other thing I would say is, even just reflecting on my own work at Metro Plus, there are discrepancies between what the environment is like in which you're accessing that digital component. So where if you have 4 or 5 people in the same room, each trying to do whatever it is that they're doing at the same time, it's very hard to concentrate or hard to have like a private conversation with a provider or have like talk therapy if you're all living in a 1-room apartment or a 2-bedroom 2-room apartment. Quite different if you have the privacy with which to engage in either your work call or your telehealth. And so I think we really need to think about not just the access to the internet as the point of the digital divide, but really what is the person's experience doing that, and is that experience equal among settings?
Great discussion, thank you. Any other comments on this question before we move on to the next question?
So if I may add one more thing, and this may be kind of an idea for organizations out there in terms of how to look at the impact and effectiveness, because as Amanda mentioned, you can certainly look at who's been using it. One of the things we've been focusing on is trying to understand the satisfaction and the perception from the member who have used it, and really separating the, yes, we know you're using this because of COVID, but asking specific questions such as, would you be using this in the future if COVID was not there? Right, and understanding a little bit more if it's specific to a system, a health system, or if it's global, right? And it was very interesting to look at that data. Another data point was also looking at how long did you wait before a physician came on board? Meaning, going in, the concept is that going through telehealth will make it easier and faster to see a physician. Is that really the truth, or is actually the wait time just as bad on the telehealth side that it is during the face-to-face? So looking at your data and kind of exploring those two would really give you lots of really good insight. And then again, as Amanda mentioned, the language part.
Great, thank you. So we're going to move on to expand a little bit to addressing social determinants of health and barriers. So the question I'm going to address to start off with Amy. So social determinants of health are often identified and addressed outside of the clinical setting. And based on our experience at Cecilia Health, these are often surfaced during conversations with our clinicians. We have also seen great success with addressing some of these SDOH barriers through remote care and disease state awareness programs that meet members where they are. The question to you is, and to the group, what strategies have you deployed to help identify and address SDOH barriers that your members may be experiencing? Amy.
I think that I think that's a great question, and I really think the answer has to be kind of a multifaceted approach, right? We can't, as health plans, we can't rely 100% of the time on providers to identify SDOH needs for our membership. We also can't rely 100% of the time on our relationships with community-based organizations to identify social determinants of health needs and barriers that our members experience. And so we have, we're really looking at it holistically. How do we create partnerships, referral mechanisms, and really data sharing pathways between all three of those groups, right? The health plan at the top with, providers and CBOs on either side of that triangle. And so what we're looking at is value-based reimbursement mechanisms to really incentivize providers to make SDOH screening a standardized and routine part of the work that they do, and then share that information back with us, the health plan, so that we can holistically share that information across all of the providers an individual might see, as well as the community-based organizations that these members may go engage with on a regular basis. And I think we've actually seen some really strong results on the opposite end, where we work directly with community-based organizations who we know are serving a pretty significant portion of our membership. Specifically, we've been partnering with some food banks who we know are interacting with our members. We have direct data coming back from them. And so we've actually engaged in, rather than hand out a foundation grant and give it to the community organization to use with however they want, we actually want to start working with our community-based organizations as if they were providers and paying them for the individual transactions they have with our membership to make sure we're getting our members access to healthy food, but then to also share information with us. So how can they help from a care management standpoint to conduct health risk needs assessments or even, SDOH screening assessments, again, so that we can collect the information and then share it so that everybody that interacts with that member or touches that member has a holistic view of what that individual's needs are and where they might be able to refer out for SDOH needs or additional care.
Thank you. Other responses?
Yeah, I'd love to jump in on this one. So I think it's really important that you really can't overscreen for the social determinants of health. I think there's really no such thing. There are so many barriers to people sharing that information with you. So I think first and foremost, we have it as part of our routine screener for our decent population. We've added this year into our HRA question, the standard questions for food insecurity. We ask about housing availability. Are they at risk of losing their housing, or are they precariously housed? We ask about their housing quality, whether their housing, they feel like their housing makes them sick, like if it has bugs or mold or roaches or rodents or others. We ask about barriers to transportation, and then any kind of violence in their home or in their neighborhood as a starting point. So I think it's, I would first say it's just important that everybody screen for these regularly, and these become the kinds of questions that we routinely ask of people, just like we ask people, like, how are you feeling? Like, have you been coughing lately? Like, we should feel comfortable asking people and destigmatizing social determinants of health and making sure that we are routinely screening in terms of using technology for it. So we did a huge outreach during COVID, reaching out to folks to just make sure, this is like, flashback to like April 2020, making sure that people knew where to get tested, knew what the, like to stay home, like to mask up and others. And in that message, we knew that there, this was like when, toilet paper shortages and all of the crazy world that was happening. We knew that a lot of our members in particular were vulnerable to like not having access to food. So we intentionally asked about things like, are you okay on your food supply? Do you need help accessing like unemployment benefits and things like that? So I think it was, sort of like whenever you're doing any kind of digital outreach, which for us was like a blessing to be able to reach out to, tens of thousands of people all at once and say, like, do you have these needs? And we worked with Amazon Web Service to create like linkages. So if you said like, yes, I have food insecurity, you would automatically be linked to a community-based organization that could help you with that. Or if you said like, no, I don't have all the medications that I need and I need like a refill, we connected you to our telehealth provider. So I think it's quite easy to screen for the social determinants of health using the technology. And we had like north of a 10% uptake of our response rate to our text message campaign, which sounds abysmally low, but it turns out that in the world of text campaigns, 10% response is actually pretty decent. The other thing is, I think when working with vendors or like people who do like disease management platforms for us or others, we do ask them to consider the social determinants of health as part of their solution, whether it's for diabetes or asthma or what have you. Because we know that a lot of the answer, if you've got asthma and you've got, mold or bugs in your home, we can give you all the steroids and inhalers that we want. It's gonna change a thing. Like your asthma is being triggered by something that needs integrated pest management as a solution. And so we do think very intentionally about disease management. What are the conditions in which people, in particular in the conditions in which people live, that might contribute to that disease entity. Same thing for diabetes. People who come in and want to talk to us about like a digital solution around diabetes, that for us, that digital solution is not complete unless it asks about like access to fresh fruits and vegetables and has some way of, with some cultural sensitivity, being able to link people up to healthier food options, recognizing that those can, in some neighborhoods, can be prohibitively expensive unless you have like good strategies around that. So I would say like those are our three things. It's making sure that we ourselves are holding ourselves accountable to collecting social determinants of health information and not relying entirely on the providers to do so. Stepping up to the plate and saying this is our responsibility too. The second I mentioned is when we're doing things like mass outreach campaigns around text messaging around particular issues, always thinking about what are the relevant social determinants of health constructs that should go along with that message. And lastly, like passing that responsibility on to the vendors and partners that we work with.
Got it. And just sorry,
go ahead,
Dr.
I was just going to add quickly that I thank you, Amy and Amanda, for sharing your strategies thus far. I think we've done some similar things here in Texas. I'll tell you, one of the things I think that bubbled up for us was that, we were aware, I think for the first time in a long time, just how significant the issues were, because typically it lands in the provider's lap, but it doesn't necessarily bubble up to the health plan as much. But because a lot of our community providers were closed during the pandemic, we found that these issues were coming right to us. So one of the first things that we had to do was take this information beyond the care management arm of the business, who typically hears about these things, but also to really look at developing resources across the health plan and really deciding that everyone who could possibly touch a member would know about what was available in the community. One of the things that we did institute was a food delivery program. So for those members that stood out to us as really being insecure, setting up an opportunity for the food to come right to their homes, because for many of our members who live in communities where there's already food deserts, to go to the grocery store, as we know, many times the shelves were empty. So with that, being able to get access to meals on a regular basis coming right to your home was one of our major strategies that I think really helped. But also too, even, things like housing and transportation, many things were compromised, I think, and exposed during this recent last year. So it really has us going back to the table and kind of revisiting ideas about how to build new partnerships with various entities in the community as they reopen. So anyway, I just think that, we're definitely trying some different things, but also trying to be aware of, kind of what's worked thus far and what hasn't worked, but also gaining insight, obviously, from across the country.
Thanks. Abdu?
Yeah, no, just to add to that, and certainly all of those are great recommendation. And I would also say even looking beyond the typical data claims and so forth, one of the big gap that's out there is providers are doing a great job screening for patient, but they're not billing for the Z codes. And obviously the policies and the reimbursements have not yet caught up into reimbursing providers for the great work that they're doing on that angle. So one of the great strategies out there is really partnering with your provider groups to capture some of that EMR extract data. Obviously, we tend to always focus on the quality data elements, but now there's more willingness from the provider groups to start to share this information. And I think the second piece is, again, just to figure out the core competencies within your organization around what are the things that are actionable that can actually help to drive in SDOH, right? Because it's one thing to capture it. It's obviously a totally different ball game to be able to address all of those different elements. And I think the more you can kind of start to figure out specifically what are those things that you want to address first, and how do you make sure that you create those partnership with not only your provider groups. As an example, one of the great partnerships that we have with some of our local health system is that they actually can call us as they are dealing with SDOH and let us do the heavy lifting in terms of figuring out the solution part, right? So we're not just leaving it on the provider organization to solve for SDOH. Obviously, resources is always a challenge for some of the smaller health systems and so forth. So I think that's a big opportunity from a partnership standpoint. And then the last piece that I also want to highlight, Emblem has across a lot of our communities, community centers. We call them neighborhood care, and we locate essentially those centers within where we have a large volume of our members, but also the underserved population. And we make those locations available not only to our members, but anybody from the community that may have a need, right? And the goal is really helping the community from the point of if they have a claim and they have a bill and they need some help understanding why they receive a bill, to getting help with housing or food insecurities. And I think staffing those locations with people that are from the community that speaks the language really helps to drive a lot of the work that we are trying to do.
Thank you. What broad responses, a broad spectrum of responses. Thank you all. I'm going to throw out the next question, which we've touched on a little bit, but looking at specific populations, I'm going to address this question to Amanda to start off. And it's as mentioned earlier, there's ample evidence showing a higher prevalence and more adverse outcomes among Hispanic and African Americans living with chronic conditions. How can telehealth specifically be used to potentially close this gap? Or do we need to take a broader look at specific underlying disparities to address it? So the question is it telehealth as an answer, or do we need to look at other disparities, and how do you combine the two? And we'll throw it out at you, Amanda, to start.
Yeah, I think it's never one or the other, right? It's always both. I mean, obviously, addressing underlying issues is critical to closing the health disparities. But until then, how do we as plans, as payers, as providers, make sure that our work doesn't continue to exacerbate the gap? I think, one is, I would say, when we look at telehealth solutions or partner solutions that are digital, when they say like, oh, we're, our initial version is available in English only and it has no other language capabilities. For us, that's not the right solution, right? Like that is the kind of solution that would further create a digital divide. So I think some of it is just demanding more out of all of the ecosystem players to say it is our collective responsibility to make sure that our products are designed to reach the most vulnerable. That's not to say that, you have to have, 100+ languages on the platform, but certainly if you're hoping to launch a solution in a market, being able to represent, beyond the top 2 is important, or at least have a solution for some translational services or other that come baked into the solution. So I think part of it is, just asking more of ourselves and of our vendors. Some of it is I think also thinking very intentionally about the makeup of staff, right? Like the makeup of our own staff, for instance. Like when I think about, as you know, as we build out our care management teams, it's really important to me that those teams look like the members we're serving, and that we represent as much of the diversity of our membership, you know, in our staff, and just being really open to, you know, somebody who I have like care managers who don't actually really speak that much English. Like they're very, very comfortable in their native language, but not so much in English. And like that has to, you know, so then that is a challenge for us in terms of like training materials and communications and rounds and things, but it's well worth the challenge when we know that we have members on the other side who get to speak directly to a care manager with whom they can form connections with. I think telehealth can be helpful in terms of reducing the barriers to access and making it convenient and available, so long as it doesn't continue to replicate some of our limitations of our, you know, brick and mortar, like we're only open 9 to 5 Monday through Friday, right? Like that is, we know that that's a model that doesn't work for it doesn't work for anybody, frankly. It doesn't work for me, but it doesn't work for, like, especially for vulnerable populations who may need more flexibility in terms of being able to access, you know, nights and weekend hours. And so I think the other thing is really thinking about when these services are available and how, and also being available when, you know, having like an on-demand feature, right? A lot of one of the things that we learn a lot about our most vulnerable populations is that their lives are fairly chaotic, right? And it is just like a series of like going here, there, and everywhere, managing things that are planned, unplanned, and it's a very, very busy time. So to be able to like make your appointment that you've scheduled 3 weeks out on Thursday at 4 p.m. is easy if you have like a fairly, you know, like regular routine life, but that's not the life of many of our most vulnerable members. And so being able to have sort of like an on-demand PRN kind of feature, as opposed to everything being scheduled and booked, and just recognizing that people might have to cancel, or, you know, they may need to, like, they may be available like surprisingly right now. And like, does your solution allow for that kind of flexibility, you know, or are you, you know, booking, you know, I think about like, you know, our kind of like pre-COVID, like the, you know, the like kind of the psychiatry world of like, you have to like book an appointment and it's like 9 to 5 and it's like, you know, booked way in advance. And it's like, you know, there's a penalty if you don't like make that appointment. Like that kind of construct doesn't work for so many people. And really thinking about how to be like flexible and nimble, and making sure that the people that are connecting to our members or our patients really have a way to establish engaging, culturally competent connections with them when the members or the patients are available. I think it's recognized. We often, I remember on the provider side, we say like, oh, these are high no-showers, right? And then when we actually looked at our social determinants of health data at Montefiore, we actually mapped it to we looked at the number of social determinants of health that somebody would have, or social risks that they would have. And it turned out the more social risks you had, the higher likelihood that you would no-show for an appointment. So instead of like thinking about people as no-showers, how about thinking about people as like, this person who's not coming to this appointment actually has a higher burden of social risk. And just changing that paradigm, I think, is a really, just changing the way that we talk about these members or these patients, I think is critical to us understanding what it is that we have to do in order to better serve their needs.
Thanks, Amanda. Other panelists?
Yeah, I think so, Amanda. I think you nailed it there at the end, right? I mean, I think the issue is, so telehealth I really view as a tool in the toolbox, right? And if you really want to improve healthcare and outcomes for the most vulnerable, for those that are traditionally underserved, you really have to meet them where they are. And you can't do that unless you really take the time. Data analytics is a piece of it, but you've really got to take the time to understand what the needs are for that population, what their specific barriers are, and they may vary, they may run the gamut. And so you might have to offer up a handful of solutions that include telehealth as one of those solutions, right? To really help improve access, make it convenient, and make it available when they need it, or when they can access it, not when it's convenient for those of us who either provide the care or pay for the care.
I think Amy and Amanda both have really nailed it and offered many items that I think to be considered. One other point I would also add is that, this population typically uses the ER the most out of all of the populations. So I think that's a great place to start when we're looking for data to understand who we're serving and actually talking to the people that need the services. Sometimes I think we don't do such a great job in healthcare. We sort of draft these ideas in our lovely office buildings, and we don't ever bother to ask the people that are receiving the services what they need. But obviously this population, I think, again, needs to be met where they are, for sure. I also think, as Amy mentioned, that telehealth is just one tool, but I think we can't do one without the other. We need to look at it from a larger perspective, all of the barriers that are contributing to the problem, while at the same time building up our telehealth platforms, things as simple as, sending people home when they sign up for your health plan with a wireless tool to take home with them as a feature or something to add. Again, a bit of an old way to approach, as many of our cities are looking to develop, citywide wireless, but it's one way to start. I think we have to start in both places at the same time and work our way towards the middle. But certainly one thing is not one, I don't think there's a magic bullet, I guess is my point.
Yep.
Yeah, and just to add to that, right, as we think about the population that we are discussing now, they're typically the most impacted from a health condition and risk standpoint, right? So somebody that has multiple chronic condition that's struggling with the social, but that's also struggling with keeping up with their medication. It's hard to tackle all of that in a telehealth visit, right? So I think part of what I'm hoping to see the industry starts to head towards is more guidance around these sorts of visit for this profile is appropriate versus this one may be more appropriate, especially if we have a history of SDOH and so forth, right? So getting more guidance there and obviously using analytics, right? I think as the panelists talked about, there's a lot of correlation, right, around people that have SDOH that are high utilizer to have specific chronic condition and looking at it by zip code. So even when we don't have data, we can start to build profiles and start to tackle the population accordingly to that.
Thanks. So we're going to take a slightly different turn here and understanding that regulation drives a lot of the funding and ability to actually make change. So I'm going to address this next question to Sabrina. So we've seen a lot of regulatory changes get fast-tracked due to the pandemic.
Mm-hmm.
What are some of the upcoming changes that you think will have the most impact on underserved populations living with chronic conditions?
I would say a lot of the regulations that were relaxed for the pandemic should probably stay relaxed. And one of the things that we saw, particularly in Texas, was the telehealth visit that automatically became reimbursable. And it was reimbursable at a regular inpatient rate. It was very easy to bill. There was special coding that went out that was given to providers to utilize. I think that, those things that we saw work, we saw an increase of upwards of 60% of utilization around telehealth visits as a result during the time of the pandemic. I think that's good data. It's strong data. It shows us that this worked. I think our legislators need to update and upgrade our regulations. Many of our regulations were written in the 90s across the country. So they have not adapted to the new individual. We look very different than what our health looked like in the 90s. There are many other things that have changed. I think we need to do more advocacy. I think our regulators need to work much more closely with our health plans. There are all these divisions around what you can do as a for-profit or a not-for-profit. You can't advocate, you can't do this. I think we need to stop focusing on the things we can't do and start working together and really looking at what are our needs, what needs to be paid for. Traditional health insurance no longer works. I think that we need to look at reimbursing the services that are needed as opposed to, some of the really outdated terms of medical necessity that, drives payment. I think that we need to really look at expanding what is offered, really expanding the scope of what health plans can offer. Because again, we're treating the whole individual, not just their illness. And as we can see, if someone never shows up to have their diabetes cared for, it becomes a much larger issue. However, if all I can pay attention to is whether or not your, A1C has dropped, then the rest of you, is an issue. So I think just in general, I would say that, a couple of things. One, a revisit to the regulations to see where we stand to date, and updating them is probably one of the larger systemic issues that need to change. I think there needs to be more communication and engagement with our legislators to talk about what our needs are serving our members. And then I think there needs to be more advocacy from the member standpoint about what is it that we need and what does need to be regulated and what makes sense. Sometimes I think our legislators spend more time policing, 2% of the problem as opposed to addressing 98% of what really needs to happen. So a lot of those standards, I think, need to be relaxed. Some, frankly, need to be deleted. So that's where I would start.
Thank you. Other panelists?
I would say the silver lining, one of the silver linings in all of this COVID work is just, showing us how quickly we can make reasonable decisions about telehealth services and telehealth availability when we need to. And I'm really glad that we probably fast forwarded like 2 decades worth of regulatory work in like 2 or 3 months. I think I look at our telehealth uptake, and from Q1 2020 to Q2 2020, it was a 10-fold uptake across every line of business, with honestly no major difference between commercial versus Medicaid lines of business. Like, everybody took to this. And even in the first quarter of this year, rates of telehealth use are still 80% of what they were in their peak of 2020. And so I feel like that is a really strong indicator that even when things can go back to, like, and I put in air quotes, normal, right? Even when physicians' offices are opened, even when people are vaccinated, this is still the way that people want to consume services. And it is such an obvious statement. Like, we're sitting here booking, our food online, our restaurant reservations online, ordering from like Amazon or what have you, but then you have to go to the doctor. Like, it makes no sense. And so I think that it's so important for us as payers and for the regulators to understand that this is an important and useful and effective way of communication for some things. And then that's where I would put the caveat. We are now, as we're reaching out to members and saying, okay, it's been a while, like yep, there was COVID, like, yep, there was like homebound status, that it is time for you to go back and get those labs done. Like, there are some things that are just not achievable over telehealth. As was mentioned before, like, it's really hard to figure out, the like prenatal exam over the video visit. And it is still important for people to be getting their physical exams at their providers. It's important for them to be getting their lab work. It's important for them to have connectivity with an ongoing continuity of care provider system or group. And I think that that's something that we have to figure out. Like, I do not want to see the world pivot from, in face-to-face to fully remote. Just like I think in the same thing as the work environment, it's great to be able to work remotely for some things, but some things work much, much better face-to-face. And I think we're going to have to sort out, like, when is it okay to continue to pay for like telehealth only versus when are we really going to put say like, no, like, really now it's time. Like, you need to go like into a clinic and have the physical exam, have all of those those face-to-face screenings done. So I think there's a lot more to learn about how we kind of go from fully remote back into this hybrid world. What should be what should be face-to-face, what can be done via like telehealth, and also to understand what's best to do. So there are some things that you can do over telehealth that are still suboptimal compared to their face-to-face, and vice versa. There are some things that are much better done through telehealth than they are in person. And I think really sorting that out once and for all, and understanding that that actually might not be such an easy, like, put it in pile A here, pile B here. That might differ like by age, it might differ by condition. There's gonna be a lot of nuances here, but I think it's gonna be really important for regulators to understand that I think this is here to stay. Like, people have acknowledged that this is how they want to consume care. Provider practices have had to figure out how to deliver that care, and we really should not lose the momentum that we've built, but we do have to make sure that those services are being used as appropriately as possible, and that people are not foregoing needed care like labs and physical exams. They're still, I don't know how old school I can consider myself, but I still believe in, like, my primary care doctor does an amazing physical exam. She will detect things, she's just incredible. And I think that but she can't do that when I'm like talking to her through video. So I think it's really important for us to just start to figure out when, how, where do we request that something be done face-to-face versus where we say, we're completely comfortable when this is done through telehealth. It's actually done better, same or better than in person.
Thanks. Other comments?
Yeah, I just want to chime in there and obviously support 100% that a lot of the things that we were able to enable because of COVID should probably stick around, right? And obviously continue to be enhanced. I think there's across the industry just a need to have some clarification around expectations too, right? So when you think about telehealth, when you think about addressing SDOH and reimbursement not always being aligned, and now some states are requiring very specific elements such as including SDOH as part of value-based provider arrangement, right? Or including things such as NCQA that does a lot of the quality measurement. Starting next year, we'll start to report out very specific race and ethnicity by metrics, right? So now we would be able to be held accountable to African American A1C control, right? Things like that. So I think the industry in itself needs to start to hold each other more accountable and start to think about how do we hire a more diverse workforce to be able to support a lot of the things that we are seeing in the community, because I think that's the other missing link, right? How do we design things that are actually meant to work for the people that we support and serve?
Thanks. Amy, any comments? We're gonna have one more quick question and then we're gonna go to audience questions.
No, on this one, I don't think I can add anything more that's already not been said eloquently by my co-panelists.
Thanks. So we actually have a group of audience questions. And I'm gonna just ask one last quick question for the group, which is, what is the one, and this is a quick question, so we can have some audience questions. What is the one most important factor that needs to change in order to close the gap in racial and ethnic disparities in chronic disease outcomes? If you had to pick one thing that had to change, what would you pick? Any order, if you want to respond.
Zip code.
I would say access.
Okay. I think access and availability.
Thanks.
Yeah, and I would say, I guess the only thing I would say is we need to stop thinking that we have the answers, and we need to actually start engaging the people that we're trying to serve, right? And figure out they have the answers. We just need to figure out what they are.
Great. All right, thank you. So we're going to turn now. We have about 5 minutes left, and I'm going to address some of the audience questions, and if the group can answer. So The first one is telehealth access from a member-patient perspective is critical, but often providers themselves may face barriers to implementing telehealth due to broadband access, particularly in rural practices, affordability from the practice perspective, and logistical challenges. How do you support the providers themselves to increase telehealth equity across communities? Good question.
I'll go ahead and jump in on that. I think it has to be folded into the rate of reimbursement, particularly as we upgrade our expectations as health plans. It has to be folded into the rate, I think, of reimbursement.
I would say, provide, like, as much as possible, provide technical assistance to providers in terms of like understanding the reimbursement landscape, which is often like confusing and complicated and ever dynamic, particularly during COVID and other situations, and just making sure that providers have the most up-to-date information about like how to bill, what to bill for, what's covered. I think we're generally not in the business of like suggesting specific solutions or, like playing, sideline IT tech support. But I think there's a huge role we can play in terms of advocacy of, making sure that that last mile broadband connectivity is available to everyone, in rural and urban settings alike. Interestingly, they both have major issues. That last mile infrastructure in New York City and the South Bronx is probably like just as challenged as it could be in like Topeka, Kansas or something. It really is like, it's dilapidated infrastructure that has suffered from significant multi-generational disinvestment. And so I think that addressing those things, whether they're urban or rural, is critical. And I think that the being sort of advocates and making sure that it's understood that there are things that infrastructure needs that need to be prioritized and addressed in a manner that is responsive to resolving inequities that created them in the first place.
Thanks. Any other comments on the question? So I think we have time for one last quick question. Many patients do not have the financial resources to make the copay payments. Is this an issue? If so, how is this issue addressed in a telehealth environment? Because most plans actually have the same copayment structure for telemedicine as it does for in-person visits. How do you address access issues if patients can't afford the copayment?
Yeah, I think that's a loaded question, right? Because everything starts with product design, right? And I think supporting our members get access to the resources. There's a lot of programs offered by many states that actually help to pay or reduce the payment impact there, and also figuring out ways that we can make sure that the members are on the right program. So you may be a member that's actually eligible for Medicaid where there's no copays, right? So I think it's about making sure that you're supporting the population and the members based on the need versus keeping the member in a benefit package that may not be the best suited for them in order to get the care that they need. I think that's one big one. And also there's a lot of organizations or federally qualified FQHCs that offer visit without any copays to people that may not even have healthcare or health insurance. So again, I think tackling it that way is certainly one way.
I would say I'll jump on that. Right. I think I mentioned in my earlier remarks that when the pandemic hit is actually when we launched our own health plan sponsored telehealth solution for both physical health and behavioral health. And that is accessible as a service at no copay. So it's not continuity of care, and it's not the same as being able to reach your primary care provider or your specialist, but it does offer at least a safety net, so to speak, for those who want to access services through telehealth, but otherwise can't afford to do so on the through the provider side. They can access 24/7 medical, like urgent care kind of capacity, as well as I think we pay for something like 10 session of mental health, like talk therapy before we have to change them, but they can get, refills for, again, we don't want people using these services as a substitute for primary care. So we want to be careful that we want to make them accessible, but not we don't want to supplant the ongoing and incredibly important primary care relationship. But certainly if somebody's having, I think I have 2 children, their number of children never get sick between 9 and 5 for some reason. They always wait till Friday, 9 p.m. at this inopportune time where no matter what, you really can't even throw money at the problem. You have to just figure out access. And so I think it's those things where you have this acute issue, time parameterize, and make sure that you as a health plan offer a solution to that, because the alternative, as we all know, is going to be the emergency department, which is a horrible experience for the member if they're not suffering from something that's life-threatening, and it's obviously not good for our healthcare ecosystem. So I think plans can offer telehealth solutions that are ubiquitously accessible, and again, don't try to compete with the primary care relationship. We hold that sacrosanct, but that's one way to address the challenges with the co-pays.
Thank you. Well, I think we've just about run out of time, and I want to say I've learned a lot from hearing the input from all of our panelists, and it's been a pleasure working with you, and I really enjoyed today's conversation.